Welcome everybody to a presentation by the Veteran Affairs Community Team of IALS. For those of you who don't know, IALS is a community-centric organization looking to accelerate cures and really revolutionize the ALS advocacy movement. And you are going to see today some of that revolutionary work. Today with us, we have Juan Reyes, who is an ardent advocate for those suffering from ALS. He was diagnosed in October 2015. Juan served 21 years in the United States Air Force as an independent duty medical technician and clinic superintendent. As a patient mentor, Juan aids newly diagnosed patients to navigate this devastating diagnosis. Juan actively serves on committees locally and nationally for the ALS Association Texas chapter, IALS, NEALS Consortium, and Patients Like Me. Juan resides with his family in Casterville, Texas. And then we have Jeremy Van Tress, PhD, is a scholar practitioner. He is the founder of Smile Inside, a nonprofit organization where he provides clinical social work services online to people with amyotrophic lateral sclerosis, or ALS. Jeremy's primary research interest is in resilience among vulnerable populations, including people with ALS, terminal diseases, military families, and child abuse and neglect survivors. His dissertation work was on the relationship between socio-ecological resilience, self-determination, and decision-making for life-sustaining treatments of people with ALS. Jeremy was selected as a 2019 Pat Tillman Scholar and became one of a select group of people to earn a doctorate after being diagnosed with ALS. He currently serves on several national level committees with the ALS Association and IALS. Jeremy resides with his family in Corvallis, Oregon. And without further ado, I will turn it over to two incredible people, Juan and Jeremy.
Thank you, Michael. I appreciate the introduction. I would also like to acknowledge IALS for creating a platform that has amplified the patient voice for the ALS community. I will begin the presentation and Dr. Tress will conclude it, opening up for questions afterwards. Next slide. What is IALS? As you can see, IAA, which we affectionately refer to it, is unique in that it truly has taken patient-centric to heart when it comes to defining its mission. Each of the teams or committees is led by and comprised of volunteers. These volunteers are persons living with ALS, families, friends, advocates, and individuals who simply wish to change the future of ALS. Some of the teams or committees that exist within IALS are the following: the Clinical Trials Team, Legislative Affairs, Familial ALS, the Thank You Squad, Community Outreach, and of course, the Veterans with the ALS team. Next slide. The IAA Veterans Team is focused on affecting and improving all aspects of service and support for veterans living with ALS and their families. Our mission and goal are to raise awareness for veteran issues related to ALS by identifying needs, connecting veterans with resources, and improving the quality of care for all veterans living with ALS. Our goal is to leverage services and access to veteran care and ultimately influence policy to identify treatments and cures. In order to affect policy through the VA, members of the IAA vet team reach out directly to the Veterans Administration Healthcare Team responsible for policies affecting veterans with ALS. Next slide. The team that we connected with, the Veterans Affairs ALS Executive Committee, is the body that develops and implements policies for everything revolving around veterans with ALS. It is comprised of neurologists that specialize in ALS, many of which are specialists that the ALS community is very familiar with. This body establishes guidelines and expectations for VA ALS clinics by standardizing the care being provided to all veterans across the nation. And it also ensures optimal quality of care. Receiving an invitation to collaborate with the executive committee was a major accomplishment for the IALS veterans team. One we hope will result in positive changes to care and services for all veterans living with ALS. Next slide. Care and services for veterans with ALS without our input can allow for gaps in the very care and services that are being developed by the executive committee. For this reason, it is imperative that the patient perspective be included in the conversation. Thus, the interagency collaboration that was developed once we had an opportunity to engage with the executive committee. Next slide. The model outlining our approach required that we not just include input from our team and the executive committee, but veterans at large, the community of veterans living with ALS. Thus, the survey that we conducted to collect input from veterans across the nation, the three primary components of the interagency collaboration was the IALS veterans team, the veterans at large in the community, and the executive team. Combining our efforts and gathering data from the community was instrumental in developing and identifying areas of improvement that we can bring directly to the veterans ALS executive team. The remainder of the presentation will be conducted by Dr. Van Tress, who will be outlining the results of the survey that was conducted. Thank you.
Thank you, Juan, for that awesome beginning and for outlining who we are at IALS and what we're doing. And I really think that that we've really paved the way for a lot of great work in the future. And I want to highlight that this project was not just done by me and Juan, it was done by a whole group of volunteers with the IALS veterans team. Over 10 people contributed to it and made it a success. So I really just wanted to highlight that, and I'm so grateful for each and every person that contributed to this project. So what we did was we formulated what's called a gap analysis survey, and that gap analysis survey, the purpose of it was to understand the care, services, and durable medical equipment veterans with ALS receive from Veterans Affairs, and to in turn identify the gaps in the services relating to particularly durable medical equipment. And so we developed that survey and disseminated it to veterans living with ALS and their caregivers. So the methods that were used, patient advocacy, an online survey with 14 open and close-ended questions. The close-ended questions were rating questions where the people that were filling out the surveys would rate their answers based on a given scale that was provided. And then the sampling method, or the way by which we reached out to the people who were participating, was called a convenience and snowball sampling method, which basically means that we reached out to people that were convenient to reach out to via Facebook groups, word of mouth, other social media platforms that would allow us to make contact with and invite people to participate. And then the snowball means that we invited those who participated to invite others that they knew to participate as well. So we did that via email, social media, and word of mouth. And then the type of analysis that we did was called, It's a manual qualitative data analysis using Microsoft Excel, and which is where we assigned participants comments into codes and categories, and basically put them into groups based on what their responses were. And then we did a process called content analysis, which is where you quantitatively add up the number of comments in each particular category and code. And then our hypotheses were that some veterans with ALS encounter barriers in receiving durable medical equipment through their prosthetics departments. And then also that some veterans with ALS do not receive durable medical equipment when they need it. Those were the two major hypotheses that we anticipated understanding more about, and we anticipated that we would have some responses that would revolve around those issues. So here are the findings of the project. We had 57 total veterans with ALS and or caregivers that completed the survey. 43%, about 44% were negative experiences. 42% were positive experiences, and 14% were average experiences. So they weren't necessarily positive, they weren't completely negative, but they were just kind of wanting to share their experience. And these are the categories that we observed as we did our qualitative data analysis. There were 25 responses that had something to do with customer service, 15 responses that had to do with equipment, 16 that were related to provider competency, 5 were related to prosthetics, occupational therapy, and physical therapy. 7 were related to respite and support. 5 responses pertained to emotional factors in dealing with ALS. 5 related to feeding tubes and nutrition. 8 responses were related to the benefits and having access to those benefits. 4 responses for respiratory therapy. 3 responses for advocacy and patient rights. 5 responses for home modifications. 3 responses related to standardized care. 3 responses related to treatments, and 3 responses to medication, and then 1 response was related to their experience with COVID in the VA. So those were the main 15 categories that were observed in our data analysis. So we also asked questions that referred to their preferred settings for life-sustaining treatments. So 41 out of 51 respondents indicated that having home care with non-invasive ventilation was the most important to them. So they preferred to be at home with non-invasive ventilation, meaning either being on a BiPAP with a mask or nasal mask, or no ventilation support at all. But they really preferred to be at home with that type of care. 35 of 51 respondents indicated that having home care with invasive ventilation was important to them, So this would be, having a tracheostomy at home. 25 of 51 respondents indicated that having residential care with non-invasive ventilation was important to them. So about half of the respondents indicated that, it sounds like they would be open to having residential care with non-invasive ventilation. And then a little less than half, 47% respondents indicated that having residential care with invasive ventilation was very important to them. So we had a wide range of approvals for each of these scenarios. And I think that this is important for the VA to understand, particularly as they work towards knowing the degree to which they're going to need to develop facilities for residential, invasive, non-invasive care, et cetera. Those will be important, as well as contracting with agencies that can help provide care in homes as well. So this is something that's important for the VA to understand and to be aware of, to provide the best care possible to meet the needs of each veteran that is diagnosed with and living with ALS. So the implications for this are such that this project was critical. It highlighted how it's critical to have specialized care for veterans with complex multidisciplinary needs. As I pointed out just in the slide previously, the VA really needs to be aware of the complex needs of people living with ALS. One critical aspect of this project was that given that it's a shared patient and VA team effort, it really highlights how the VA and patients can work together to better understand patient needs. And this results in shared funding and shared resources so that the VA is not overburdened, as well as so that people living with ALS and can contribute. Which also leading to it can increase satisfaction and morale amongst the patients. And then it also will result in improved processes and care coordination across specialties when dealing with ALS, and improve care that meets the needs of veterans. And it can also lead to legislative action in terms of understanding better the needs of veterans living with ALS and their caregivers. And it gives some tangible ideas for those who are working with people living with ALS to look into and to understand more about, in order to lobby our legislators for the resources that we need to provide that care. So our conclusions and recommendations. The interagency collaboration model is mutually beneficial for veterans with ALS and Veterans Affairs. It provides better care, shared burden for ascertaining veterans' needs, improved policies and procedures at Veterans Affairs. Some of the recommendations that we have is to report the survey feedback to the VA ALS Executive Team, which we've already done, and they've actually taken a lot of this information to heart and are actually implementing and considering it as they go about improving and redrafting directives and other policy changes within the VA. And then we recommend that we use this to communicate veterans' needs and advocate that they be addressed. And then that we continue to collaborate with patients on projects like this so that patients have some autonomy in the broader process and broader policy making for veterans.